Welcome to West Midlands Evidence-Based Emergency Medicine, applying rigorous data and research for optimal patient outcomes.
All right, everyone. Hello. On behalf of West Midlands Evidence-Based Medicine, let's talk about something that, well, I'm sure it crops up for all of us on the shop floor. You know the scene. It's a late one. You've got a child with a pretty minor head injury. The parents are understandably anxious, and you're there weighing up the pros and cons of ordering that CT scan. We all know there's a radiation risk, but what is it really? So let's just cut straight to the chase. That pediatric head CT, what is the actual evidence-based cancer risk? For years, we've been working with, well, let's be honest, pretty ropey estimates, often based on data from atomic bomb survivors, which is hardly the ideal comparison. But now, finally, a major new paper has come out that gives us the clearest picture we have ever had from a real-world clinical setting. Right, so let's get stuck in. The paper is by Smith-Bindman and her colleagues, and what they've done is a massive retrospective cohort study. It's actually the first of its kind in North America, and it's exactly the kind of work we've needed to start putting some solid, reliable numbers on this risk. And I'm not kidding when I say massive. The study looked at over 3.7 million children across the US and Canada. That sheer scale is what gives its findings so much weight, so much statistical power. It makes it very, very hard to ignore. So what were they actually trying to do? Well, their aim was crystal clear. They wanted to pin down the link between the total radiation dose a child gets to their bone marrow from all medical imaging, and that's not just CTs, but X-rays and fluoroscopy too, and their risk of later developing a blood cancer like leukemia or lymphoma. So what did they find? And the headline finding? Well, it's probably not going to shock you, but it's so important that it's been confirmed so clearly. They found a definite dose-response relationship. Put simply, the more radiation a child is exposed to, the higher their risk. Now, this table just lays it all out beautifully. Look here at the low end, a dose you might get from multiple X-rays that still carries a relative risk of 1.41. That's a 41% increased risk compared to a child who's had no exposure. Then you jump up to the middle row, our bread and butter, isn't it? About 1 to 2 head CTs worth of radiation, and the relative risk climbs to 1.82. That's an 82% increase, and as you can see, it just keeps going up from there. It's a clear, undeniable ladder of increasing risk. Okay, but relative risk can feel a bit abstract, can it? What does this mean in terms of actual numbers of kids? Well, this is the reality check. For every 10,000 children who were exposed to a higher dose of radiation, that's 30 milligrays or more, there were about 26 extra cases of blood cancer by the time they turned 21. It's a small number in absolute terms, yes, but it is a real measurable harm. Right, but we're all evidence-based clinicians here. We can't just take these findings and run with them. We have to kick the tires on this paper a bit, really understand its strengths and, just as crucially, its potential weaknesses. The strengths, well, they're pretty obvious. That gigantic cohort size, for one, the fact they painstakingly calculated the dose for each individual patient is a huge plus. And they included every type of imaging and had a genuine, unexposed group to compare against. But, and it's the big but with any retrospective study, isn't it? There's the potential for reverse causation. And that brings us to the absolute elephant in the room. You have to ask, could it be that the child was already developing a cancer, and the early symptoms of that cancer are what prompted the doctors to do the scan? If that's the case, the scan isn't the cause of the cancer at all. It's an effect of the disease already being there. And this is where I think the authors were really quite smart about it. They anticipated this criticism and tackled it head-on. They did a clever lag time analysis, where they ignored any scans done in the 6 or even 24 months immediately before a cancer diagnosis. And what did they find? They found it was incredibly rare for a scan in their final analysis to have been done for symptoms of a brewing cancer. In their own words, reverse causation just doesn't explain what they found. Okay, so we've got a really solid study with some pretty clear and frankly concerning findings. So let's bring it back to the shop floor. What does this mean for you and me on a hectic shift in a UK emergency department? This is the absolute key takeaway. The message here is not stop scanning kids. Absolutely not. We all know that medically indicated imaging saves lives every single day. The goal isn't avoidance. The word we need to be thinking about tattooing on our brains is optimization. So what does optimization look like in practice? Well, it's about being rigorous, justifying every single scan, and crucially, documenting our reasoning. It means we have to actively think, is there an alternative? Can we use ultrasound? Can we use MRI? It's making sure our radiographers are always using the proper low-dose pediatric protocols. It means we should be the ones questioning requests for repeat imaging. And perhaps most importantly, it's about talking to our junior colleagues, talking to patients and their families, and sharing this decision-making. Okay, so let's boil it all down. The bottom line. If you remember only one single statistic from all of this, please make it this next one. 10.1%. What is that? Well, that's the population attributable risk. The authors calculated that in their cohort, just over 1 in every 10 childhood blood cancers could potentially be attributed to radiation from medical imaging. Let that sink in for a moment. 1 in 10. That is, well, it's a sobering thought, isn't it? It directly connects the small individual decisions we make in the ED every day to a pretty significant population-level problem. So that really puts the onus back on us as a professional community. This evidence isn't here to scare us or to make us feel guilty. It's here to empower us to make better, more informed decisions. So I'll just leave you with this one question to think about. Given this new powerful evidence, what's one tangible thing that you can change in your department, starting from your very next shift, to make sure we are truly optimizing every single scan for every single child? Something to think about. Thanks for listening.